Hello, this is Kim Jong-dul. Today's topic is part 2 of problem list in orthodontic diagnosis. This is a 60-year-old elderly female patient with chief complaint of anterior crowding. From the submaxilla vertical, the lower lip is retruded. In panoramic X-ray, many of posterior teeth are treated with dental crowns, and some are endodontically treated as well. In intraoral photos, anterior crowding and multiple restorations can be observed. In PA X-ray, there are not any significant asymmetric findings. ODI 70A PDI 65 CF 147 indicate class 2 high angle. There is an anteroposterior problem, and the mandible is directed counterclockwise. FMA is steep 40, UOP is normal 12, and POP is steep 17. Yon to FH is normal 111, but the lower incisors are labially inclined 97. Due to acute IIA 111, the lips appear protruded. This is the problem list for this patient. 1. The patient's chief complaint is anterior crowding. 2. Oral hygiene is good. 6. In profile view, the mandible is protruded. 7. In panoramic X-ray and intraoral photos, multiple restorations are observed. 9. The skeletal pattern is class 2 high angle. IIA is acute 111, and POP is steep 17. Let's discuss this patient's practical problem list. 1. Protrusive lips are treated with extraction. 2. Lower anterior crowding requires extraction to treat. 3. Multiple restorations can be either refabricated or extracted. 4. Endodontically treated teeth need to be reevaluated, and they can be extracted if extraction is needed. 5. However, this is an elderly patient in 60s, and she would prefer to retain her teeth as much as possible, much more than aesthetics. In other words, function is more important to this patient. 6. To flatten steep POP, the lower second premolars can be extracted if premolar extraction is needed. 7. Due to low CF, there is a high chance of bite opening with non-extraction treatment. In this case, it is appropriate to treat with extraction approach. Overall, the possible treatment plan can be an extraction treatment. The problems with non-extraction treatment are 1. Deterioration of lip protrusion, and 2. Bite opening due to low CF. Therefore, premolars need to be extracted, but the important point here is which teeth to extract. It should be contemplated whether to extract the upper first premolars and lower second premolars, or the second premolars in both the maxilla and mandible. During diagnosis, first explain to the patient about facial asymmetry and the 2 possible extraction options. In the maxilla, the second premolars are treated with restorations, and when the extraction of upper second premolars is considered, the maxillary sinus should always be assessed for pneumatization, especially in case of extraction of the lower second premolars. It is advisable to explain that 1 mm of space can be remained after treatment. Favorable occlusion and profile were achieved by the extraction of upper and lower second premolars. If space remains in the second premolar area, it can later be closed when the adjacent teeth require restorative treatment. This is a 12-year-old female patient with chief complaints of anterior crowding and protrusion of upper anterior teeth. From the submaxilla vertical, the mandible is retruded and the maxilla is slightly protruded. In panoramic X-ray, impaction of tooth 13 is observed, and as a result, tooth 12 is labially inclined. The prognosis of tooth 12 appears to be questionable. There is an anterior crowding in the lower arch. From the front, lip seal does not look comfortable, as is evident by the mentalis muscle activity. In PI X-ray, slight asymmetry is observed. Due to shorter ramus height on the left, there is a lip canting with the left mouth corner slightly higher. ODI 82 IPDI 75 CF 158 indicate class 2 low angle. FMA is steep 30, yon to lip line of 7.8 mm means overruption of the upper incisors. And both UOP and POP are steep. Because of class 2 malocclusion, the upper incisors are lingually inclined 100.8. and the lower incisors are labially inclined 103. However, the interincisal angle is 125, and the lips are protruded. Let's take a look at this patient's problem list. 1. The patient's chief complaints are anterior crowding and protrusive lips. 2. Oral hygiene is good. 3. 4. There are not any significant problems with growth and TMJ. 6. From the front, facial asymmetry and lip canting are observed. From the profile, the maxilla is protruded, and the mandible is slightly retruded. 7. In panoramic X-ray and intraoral photos, the impaction of tooth 13 caused root shortening of tooth 12. 8. The upper midline is slightly shifted to the right from the facial midline, but the lower midline is normal. 9. The skeletal pattern is class 2 low angle. Interincisal angle is 125, and both UOP and POP are steep 19 and 23, respectively. Here is the practical problem list of this patient. 1. Protrusive lips are treated with extraction. 2. Anterior crowding is treated with extraction as well. 3. Tooth 12 is not in a good position, and its root is shortened. So this tooth can be extracted if extraction is needed. 4. Impacted upper canine can be treated by traction, or it can also be extracted. 5. Due to distal inclination of the lower canines, the lower second premolars should be extracted if extraction is needed. 6. Since CF is high, non-extraction treatment should be carried out if possible. 7. Because of steep UOP, if extraction treatment is needed, the lower second premolars should be extracted. 8. Labioversion of the lower incisors should be treated with extraction. 9. Root shortening of tooth 45 must be noticed to the patient, and this tooth can be extracted if extraction is required. As you can see, there is a higher number of extraction as the possible solution, in accordance with the practical problem list. In this patient, the only pros of non-extraction treatment is high CF. On the other hand, premolar extraction is appropriate for protrusive lips, anterior crowding. Root shortening of teeth 25 and 45, distal angulation of the lower canine, and labial inclination of the lower incisors. What are the problems of non-extraction treatment? Lip protrusion will be more severe. Tooth 13 has to be orthodontically pulled, and the shape of tooth 12 is unaesthetic. Even if tooth 13 is surgically pulled and shaped into tooth 12, the facial profile is likely to be unaesthetic. On the other hand, what are the problems of extraction treatment? Due to high CF, there is a high chance of bite deepening, so it has to be controlled during the course of the treatment. Nonetheless, this patient needs an extraction treatment. Then the next question is which teeth to extract. In other words, the two extraction options for the upper arch are whether to extract the upper first premolars on both sides, or the lateral incisor on the right and the first premolar on the left. The problems with the extraction of both upper first premolars are 1. Traction of tooth 13, and 2. The possibility of extraction and replacement with dental implant of tooth 12 due to root shortening. On the other hand, teeth 12 and 24 can be extracted, and the upper right canine can be substituted for the lateral incisor. In this case, the canine cusp tip requires grinding enamelloplasty. In case of steep POP, is it better to extract the lower first premolars or the second premolars? It is appropriate to extract the second premolars. When the lower canines are distally angulated, is it better to extract the first premolars or second premolars in order to correct the mesial angulation of the roots? Of course, the first premolars can be extracted and the canine roots can be moved into correct positions, but it will be time-consuming. As you can see, this movement is theoretically possible, but not easy. In other words, it is much easier to extract the second premolars and simultaneously move the first premolars distally and upright the distally angulated canines. So keep in mind that the second premolars should be extracted if the lower canines are distally angulated, and extraction is required in the mandible. In case of square U-shape arch form with anterior crowding, the incisors are likely to be labially inclined if non-extraction treatment is carried out. If the lower first premolars are extracted, it will be difficult to adjust the arch form. Therefore, when extraction is necessary in a square arch form, it is appropriate to extract the second premolars. During diagnosis, first explain the facial asymmetry and then the 3 possible treatment plans. 1. Upper and lower first premolars extraction. 2. Upper first premolars and lower second premolars extraction. 3. Upper right lateral incisor and left first premolar and lower second premolars extraction. Which option is the best for this patient? Option 3 would be the best. That is, favorable treatment outcome can be achieved by the extraction of the upper right lateral incisor, upper left first premolar, and the lower second premolars. In the post-treatment photos, the upper right canine in the lateral incisor position is observed. Class 1 canine and molar keys and favorable profile were obtained. Of course, the gingival margin of tooth 13 is not favorable, but this can be adjusted later after growth by grinding it and leveling through partial orthodontic treatment. Exercise caution when grinding teeth in growing patients, as there is a high risk of pulpal damage. To sum up, it is important to create a problem list and come up with possible solutions. Follow this step-by-step checklist to evaluate the malocclusion. This procedure may be irrelevant for normal criteria. But if there are problems, they need to be carefully assessed for appropriate treatment planning. Thank you for watching.